examples. Kelly will give us a more more specific examples from Pennsylvania that's been working through this framework. And then Susan's going to walk us through some tools and resources that are available to you now. We're hoping to have some dialogue in the chat room. We had over 70 people registered, so we know that everybody's on mute and in the chat room. And our support people for the chat room are Nancy Lever. I'm thinking she's joining us from the National Center for School Mental Health. And also Kelly Perales and Susan and myself. And then we also have, I noticed Julie Cartel is here from Illinois. When we talk about trauma-informed interventions, Julie may jump in some of our other Illinois partners with ISF. Sherry Luking and Allie Hearn, feel free to support us in the chat room as needed. And we wanted to start with a quick poll. So Colin, if you could put the poll up, we wanted to get a quick read of who's on this call. So we have two quick polls that Colin's going to share with us. Colin, can we get the first poll up there? There we go. So we're just asking to see who all's on the call here to help us a little bit better meet your needs. Do we mostly have people employed by a community agency, or do we have people employed by a school district? So looking at the poll, it looks like we have a lot of people employed by school systems. Some people are changing their minds. Since we were at 70, we went down to 64. So, and we have a fair amount of people who are represented by other agencies, so that's helpful for us to know. So Colin, we want to end that poll and move on to our next one, if we could. So our next poll is we'd like to find out what's your role in the agencies that you work for. So we're looking for school administrator, community agency administrator, school-based clinician, community-based clinician, family representative, teacher, or please feel free to say, I don't know, and just withhold your vote. But looking to see, we have administrators, we have a lot of clinicians, we have a lot of school-based clinicians, which seems to be our highest number so far. If everybody can respond to the poll. Okay, so we have some school administrators, community-based clinicians. No, nobody's identifying in that mode. We do have some family reps, which we know we would have with a system of care sponsored webinar today. So we welcome people here representing Family Voice. And thank you, Colin. Can we move away from the polls and onto our presentation? Thank you very much. So moving forward, now that we know who's here, the brief history on the screen right now is not news to anybody here. And we all know that we have to work together, because even when we join forces between school and community providers, we know that there still isn't typically enough. We also know the history of labels and places being confused with interventions, and sometimes people inside schools refer to a program as an intervention or a classroom that a student's located in. And we also know we've had historically, in spite of the years of system of care implementation, separate delivery systems. And the biggest issue for us, the biggest change we've seen in the past 5 to 10 years, has been moving away from minimal accountability for outcomes for our most vulnerable populations to using evidence-based practices and being focused on outcomes. The data up on the webinar screen in front of you, again, preaching to the choir, is that, we're talking about a very large number of youth entering schools every day who are at risk of or already have or struggling with a mental health condition. And most children and youth in our country do not get any treatment, and school ends up being the de facto treatment site, mostly through special education, mostly with very poor outcomes. And we also know about the juvenile justice system as the system default, which leads to some very horrific results, the least of which is not the suicide rate among young adults, On the good news side, there's a lot of things happening in the education world that we wanted to make sure our system of care partners knew about. And under the Now is the Time initiative out of the White House, a very comprehensive plan with a large array of grants that have been funded from U.S. Department of Education called School Climate Transformation Grants. And also SAMHSA has awarded Project Aware grants. And there's also Department of Justice, School Justice Collaboration Program. So I'm thinking we have a lot of participants on this webinar today who live in communities where one of these grants is funded. And the push on all these grants is to expand the continuum of mental health knowledge and support available to kids through schools. And we're extremely excited about last year's federal guidance report that led to these grants being funded. And you notice the picture up in the corner, both justice and education represented side by side, which is what we want to see in our communities. And one of the most exciting aspects about the new push out of the U.S. Department of Education and Justice is everybody should now have gotten the memo. Zero tolerance does not work. It results in disproportionality. It results in inequity. And our kids, our youth who struggle with mental health issues have borne the brunt of the ill effects of zero tolerance in terms of being pushed out of school. So we're very excited that our federal leaders came public with the Civil Rights Report saying zero tolerance does not work. The other good news about the climate we're in today is there's a much more mainstream conversation happening about mental health. Schools are more active in the dialogue about the mental health needs of their kids and their families. Prevention and early detection are a huge focus in the U.S. DOE School Climate Transformation Grants and the AWARE grants. And a point that we celebrate continuously is we are moving away from counting how many kids access services and instead moving towards how many kids who access services are actually experiencing a good outcome. So hopefully we are moving beyond the days where we consider access to treatment the outcome we desire, but we want outcomes to treatment. So we have a lot to celebrate, but we have a lot of work to do. This is a picture up on the screen now of a school district somewhere thinking that they're keeping students engaged by, as an alternative to suspension, having them wear orange vests and walking around picking up garbage. And our message back is that is not a good example of alternative to suspension, and we can do a whole lot better than this. And our positive behavior intervention and support, finally known around the country as PBIS, representing a school-wide application of a decision-making framework to guide the use of best behavioral practices. And we're thinking many of you on the call we're going to ask in a moment are probably familiar with teams functioning in schools, looking at data and designing behavior interventions and other social-emotional supports and interventions based on data and using a prevention-based framework. There's a great deal of research, experimental research has hit in the past 4 or 5 years, and those of you that are interested in that, reading further, you can see the references underneath the screen. But the big issues are on top here. We know that if schools implement a multi-tiered system well, and if they implement it with fidelity and use evidence-based behavior practices school-wide, we can see the improvements noted on the screen, including what are referred to as highly valued indicators in the education community, not only reductions in problem behaviors, but improvements in attendance and safety and academic performances. And there's studies using PBIS to reduce bully behavior. And that is due to the organizational efficiency, which also results in less staff turnover, teacher efficacy, and overall improved social-emotional competence. So the features of a system are also known, PBIS system is also known as MTSS. So some of you may have heard that newly adopted language, multi-tiered systems of support. And the convergence in mental health is the same. We want to invest in prevention and screening and early intervention for students, not at benchmark. We want to use scaled up interventions, and we use progress monitoring and a problem-solving process at all three tiers, which we believe lays out a perfect foundation and framework, along with the use of only evidence-based practices, a perfect framework for the installation of mental health. So let's take a pause here. And Colin, if you could put up the other poll, we just want to know how many of you are familiar with school-wide PBIS or MTSS in terms of having heard of it before. And we have more yeses than nos. Still increasing. This was our hunch, and for those of you who are not familiar with the application of school-wide PBIS as a multi-tiered system of support, I'm hoping the brief discussion of core components and a little bit more as we go through here will inform you, but we also direct you to PBIS.org, which is the National PBIS Center website, and lots of information about the implementation of school-wide systems of positive behavior support. So Colin, if you could take us back to the, thank you to those who are responding. We really appreciate knowing who's on the call. So what are the advantages of having this framework in school? Well, the advantages are it's a framework that promotes effective decision making, and then of course the practices improve the climate and learning. The big key is we're changing the adult behavior, so all the adults in the school are expected to use research-based behavioral practices, and that means reducing the punitive approaches and reducing the use of out-of-school suspensions and office discipline referrals. But it's expected by all adults in the building. We feel like the PBIS framework is critical and it's important, but we know that more is needed. For example, many of the schools, after they install Tier 1, where all the teachers are expected to use high rates of positive instruction, positive feedback with kids, etc., we know that schools struggle with scaling up to the higher tiered interventions. We also know that a lot of schools stumble with their PBIS implementation and only pay attention to office discipline referrals and suspensions of kids with what we call externalizing behavior. And we know that we need much more refined systems and screening procedures to find our youth with internalizing issues. We also know that there is other data that should be brought to the table in schools other than office discipline referrals, suspensions, failing grades, tardies, and attendance. What about the data from the community that tells us the broader context in which our kids learn and grow in? Our partners at the National Center for School Mental Health refer to a concept of mental health as expanded school mental health. And they also, in the school mental health world, are talking about a full continuum of effective mental health promotion intervention for kids, all kids, not just special ed kids. Our National Center for School Mental Health supports the system of care, values, and principles greatly, talking about a shared agenda involving school, family, community system partnerships. And when we say family, we include youth as a strong element in that regard. We also see the system of care principles and values in the Center for School Mental Health definition of expanded school mental health when they speak about collaborating with community professionals and augmenting the work of school-employed staff versus setting up separate systems in the school. And we know that schools that do have school mental health providers, that there are some states that actually fund school mental health providers through their state departments of mental health. We know that having additional players at the table improves access and early intervention and reducing barriers. So we know that the PBIS Center, the System of Care Center, and the National Center for School Mental Health all share the same agenda. However, what we saw is when there was school mental health providers, what we saw is a lot of them came in separately, developed in an ad hoc manner, and lacked an implementation structure, and therefore lacked the sustainability that is needed. So taking all this information into consideration, we put together a monograph called The Development of an Interconnected System Framework for School Mental Health. The link is in the PowerPoint, which you can download. And Susan Barrett, Mark Wiest, and myself were the editors of this monograph, and it involved a lot of practitioners from around the country. And our purpose in putting this monograph together was to describe this implementation framework using the basic foundation of the PBIS system: multiple tiers, problem solving, use of data, selection of interventions based on data, progress monitoring with fidelity, progress monitoring with outcomes. So we define how that framework works. And then we also in the monograph describe some current implementation efforts across participating states and communities. And we define implementation research and tools. If you're from one of the states or communities listed on the screen, then you will be able to read a little bit about something in your state. If we could just take a moment and put up the next poll, Colin, we wanted to find out how many of you have already seen the Interconnected System Framework monograph that's been available online for about, well, since October of 2013, so a year and not quite a half, or maybe a year and a half. So we're kind of evenly split here a little bit. Some of you are familiar with the monograph, some of you aren't. We're going to walk you through a little bit of it, and then you'll be able to download it and use the tools in it, and join us in other webinars to learn more about it. Thank you, Colin. We could switch back to the now, and hopefully we've helped Phoebe Malloy with her audio. Okay. Okay, so rationale. We've already gone through this of why we need to work together, why we need to have a blended framework, but we know and why we need to expand to more of a multifaceted education and mental health support. We know that the usual systems haven't integrated as well as they have, and we know that academic and behavior and mental health supports need to be officially blended. So by adopting an interconnected system framework, we believe we can enhance the outcomes overall, promotion and prevention, with schools serving as protective factors, and with problem-solving teams having the system of care principles and values reflected with the full voice of school, family, youth, and community voice, the use of data for decision-making. How do we screen? How do we select? How do we monitor outcomes? We're talking about layers of support instead of a mental health person occupying space in the building and taking referrals. We want them to be a part of the behavioral health system in the building. So when we define ISF, we talk about a structure and process guided by key stakeholders with people who have the authority to reallocate resources. So while we're talking about tiered prevention logic, cross-system problem-solving teams, use of data, progress monitoring, and active involvement, we're also talking about this being guided by a district community team, because people's jobs and functions sometimes shift once we move to a blended model, and we'll get into more of that in a moment. Here's an example of what we call the traditional model, would be that each school works out their own plan with a mental health agency. In the integrated model, we feel very strongly that these decisions need to be made from the district level, and that the district leaders and the community leaders need to put a plan together for integration across the school district. Even if every building isn't going to have blended staff at the same time, It should follow a district plan. We found that it really does not work to have the practitioners at the school level and the community level try to figure out how to work together. There's too many barriers that they will come across. So the monograph talks strongly about the district team. Here's an example from Northern Illinois, Elgin, Illinois, second largest school district in Illinois. If you look at the range of providers and agencies up on the screen here, that's an example of a district community team that meets regularly and actually breaks into work groups to address the development of different systems across the schools. Come back to that in a moment. They have developed a mission statement in this community school alliance, is what they call their district community team, and they have memorandums of understanding about how to position the community providers, for example, from the Boys and Girls Club or the Hanover Township Youth and Family Services. This mission statement, this community team, and memorandum of understanding is how they move forward to put people inside their building. Another example is from Scranton, Pennsylvania. You'll hear a little bit more about this in a few minutes from Kelly Perales, and those are the representatives on their team. Another example of the ISF is instead of having a mental health counselor housed in the building to, and notice the quotes, air quotes, see students, we want to get away from that language. We want the mental health person to participate in teams at all three tiers and help choose the intervention based on data. So we want to change the language from that clinician is, quote, you can't see me, I'm using air quotes, is, quote, seeing that student, to saying that student is receiving, and then fill in the blank, a clearly defined intervention. And that intervention is decided from the dialogue at the team level. So for example, the diagram up on the screen at this moment looks a little complicated, but let's take a minute and unpack this. This is what a multi-tiered problem-solving process looks like in schools doing school-wide PBIS, of which there are over 20,000 schools using similar models across the country that are connected with our national center. We strongly expect that there's a lot more than that, but those are the ones that are connected to the national center. But the Tier 1 team, and this is a Tier 2 team, this is a subsidiary Tier 2 team that does problem solving, and a Tier 3 team. And the participants on these teams have typically only included school personnel, and what we're advocating is an interconnected system framework model, that there will be community representatives, family and youth representatives on these various teams to make decisions about which interventions are necessary for which groups of kids. And of course, this will be based on data. In our old model, unfortunately, in special education and in mental health, we spent decades without clear data being used to monitor intervention. Some of you may be familiar with the dialogue that goes something like this. How's she doing in that group? Great. I think she's doing fine. She likes it. We'll keep her in the group. That's the kind of dialogue we don't want to have anymore. We want to have a dialogue where we talk about exactly what are the skill sets, coping skills, etc., being taught in the group, and what is the data that indicated the young lady needed to be in the group, and what is the data the team's going to monitor to see if the group is actually having the impact that's intended. So we want to move towards, in our integrated model, where community providers are sitting on these teams with the school providers and are collectively together looking at data. The example on the screen now that I'm using is a particular social academic instructional group, and decide which groups we need to have, which skills are going to be taught, and which data we're going to use to monitor effectiveness. Up on the screen in front of you now is examples of the different types of school and community data that we have seen our interconnected system framework, such a mouthful, so I'll call it ISF, our ISF sites use So for example, I'm going to go right here to food pantry visit. A high school in Illinois that had community providers on the team. They were talking about the increase in family visits to food pantries in the community around this one high school, and how that is impacting the number of kids who are perhaps coming to school in need of some more social emotional support than previously had. Also, community providers know things like calls to crisis centers or an increase in young adults going into local hospitals for suicidal ideation or suicidal attempts, for example. And community demographics, the number of families accessing homeless shelters in the community, the number of families in the community who have an incarcerated family member. All of these contribute to and could help design interventions at the school level. On that note, I have an example up on the screen from a high school in Elgin, Illinois, where they instituted a group in partnership with their local community providers for mental health. They found kids at risk of dropping out of school, at risk of getting arrested based on A, behavioral data at the school, followed up by B, risk factor checklist. Then they designed groups particularly for these kids who were not engaged in school. And the mental health provider made it quite clear that the school data wasn't enough to determine the effectiveness of the group, and added self-surveys, self-assessment surveys, where kids reported whether or not they felt connected to their school pre-group and post-group, whether they felt respected and felt important while at school. And the mental health provider in this example brought some research to the table for the school team to push them further to look beyond office discipline referrals only as the way to tell if kids were feeling increased support. So I'm going to, at this point, turn the presentation over to Kelly Perales. Let me tell you a little bit about Kelly. She works with Community Care Behavioral Health in Pennsylvania, and she helps manage and oversee school-based mental health teams that come into the schools. And her example she's going to share through an integrated model with the PBIS framework in the schools. And this is through a managed care system in Pennsylvania. And Kelly is a big leader with our ISF implementation nationwide. She's part of our community of practice group and has been sharing with us for years the development of the interconnected system framework in Pennsylvania, which is a site for system of care grants, a site for safe schools grants, a site for a school climate transformation grant, et cetera, et cetera. So at this point, I'd like to turn it over to Kelly to share with us a little bit more in-depth examples from Pennsylvania. Kelly?
Hi, good afternoon, everyone. I see that there are a few familiar names on the call, and you may have heard some of these examples in the past. But again, as Lucille said, as we move along in time and our experiences, we continue to refine the processes and the system features, as well as hone in on some of the new tools that you're going to see here in a little bit. I think I need to have someone tell me how to forward the slide. Okay. Essentially, as Lucille said, we have a community of practice for school-based behavioral health in Pennsylvania. And over the last 7 to 8 years, we have focused first on one strategy, which was the implementation of PBIS, or multi-tiered systems of support, across the Commonwealth. And in more recent years, a couple of other strategies have come out of that work because of our learning. And so with our PBIS implementation, we've been involved in several projects with some of our national partners, including Renew, which I see Lisa Brunschweiler, one of our state trainers, is on the webinar today. universal screening, which is a critical piece of especially identifying early those young students who may need additional supports through mental health or other social emotional learning in addition to behavior needs. And positive family support and family checkup, which is a way to further engage families, especially at tiers 2 and 3. Recently, we were awarded one of the Safe Schools Healthy Students grants through SAMHSA and have 3 sites, 3 counties that are system of care counties. And then within those counties, we have 3 school districts implementing PBIS. And so the goal is to really further blend the interconnected systems framework with our system of care partners and, of course, those other child serving systems such as children and youth and juvenile justice. And then finally, we are working on the Youth Mental Health First Aid. We were not one of the Project Aware state grantee awardees, but have committed to continuing the work, which is really how we've done a lot of the work in our community of practice. And so we have folks who are working through that train the trainer model. In the Scranton School District, which is where I'm going to share the examples from today, this was one of our early ISF demonstration sites. And we got started in about 2009. The statistics that you see on the screen now are from this school year in terms of their total enrollment, the number of children they have with special ed IEPs, the percent for free and reduced lunch. There's a huge percentage of children who are living in poverty in the Scranton School District. And then I think the most interesting data point is that they do have a lot of children who move. And so what they mean by internal transfers is they may be attending school at one elementary school this week and next week because of a circumstance over the weekend. Maybe they were evicted, maybe they changed housing for another reason. They might attend a different elementary school. Let alone they also have a lot of children enrolling throughout the school year. There are 2 high schools in the district. Oops. Somehow, there we go. And both of the schools have a community mental health provider who provides a team to the buildings. And this model is one that was developed by Community Care in partnership with providers, family representatives, our county partners, and our school partners, where we have licensed clinicians and bachelor's level folks who go into the schools and support a cohort of youth and their families across homeschool and community. And again, this is something we started in 2008 and have teams in several school districts across the Commonwealth. But in Scranton, you can see here that we have these teams in place in almost all of the school buildings. And those teams are really working closely with the schools as well at tiers 1 and 2. And then we really started out in just 2 elementary buildings, including for tier 1. And now we have all but 1 implementing tier 1. We have tier 2 in place at several of them. And at the intermediate buildings, all 3 have all 3 tiers, and then also that includes our community mental health teams. I'm going to kind of skip past these slides because I want to get to the data, but this kind of tells you a little bit about where we have our teams, and you can refer back to the map as well, because Community Care, as Lucille said, is a nonprofit behavioral health managed care organization, and so essentially we're responsible for individuals with medical assistance or Medicaid, and we work closely, as I said, with our provider community because we see ourselves as providers to really ensure that youth and families get the services that they need for their behavioral health needs. one of the things that we wanted to ensure when we started these teams was that we would be tracking outcomes for all of the children and families who participated. So prior to this model, again, this is I think common in school mental health or any form of mental health, is we really haven't been tracking outcomes. We're not checking to see, when someone participates in therapy outside of evidence-based practices, are we making sure that the interventions that we're choosing or using, the therapeutic techniques, are really having an impact, that kids are doing better in all domains, home, school, community, and that families are feeling like they have the confidence to manage their family needs and wellness, and that overall they feel like they're doing better. And what we have also done is compared those youth who are part of our school mental health teams and attend a school where PBIS is being implemented with fidelity, compared to those children who are part of our school mental health teams and attend school where they're not implementing PBIS, or if they are, they haven't reached fidelity yet. And what we have seen is that for those children enrolled on the teams who are attending PBIS schools, we see improved functioning. And that's both for child functioning and family functioning. And we also know that in those cases, there seems to be more collaboration between the family and the therapist. And we also know that we have more improved communication and collaboration between the family and the school partners. So here is a graph, and this data comes from the Child Outcome Survey, which is one of two tools that we use to measure progress. And this tool is actually developed by Community Care under the leadership of Brad Stein. And it is looking at the family's perception of how their family is functioning and how their child is functioning. So you can see here the comparison of PBIS schools compared to non. And this here is for child functioning and for therapeutic alliance. And so again, that's sort of how the family perceives they are able to work closely with their therapist in order to achieve the treatment goals that they've established together. This graph is actually taken from SWIS, the School-Wide Information System, and so this is a database that the National PBIS Center has where school buildings can enter office discipline referral information. Now, I have two examples that I'm going to share with you that both have data that originated out of this Swiss system, but as you saw, we really moved way beyond just looking at acting out problem behavior. But this is from West Scranton High School, one of the two high schools in Scranton, and what happened last year is they started implementing PBIS at the start of the school year, and in March, we were having a kind of team meeting, and what they realized is that their biggest problem behavior was tardies. And so they started digging a little deeper into the data, and what they uncovered was, I'm sorry, I'm waiting for the slide to advance here, that most of the tardies were in the morning, so at the start of the school day. What they also realized is that it didn't seem that there was one grade in particular where most of the tardies came from, although you can see here there is a little bit of a difference. It's not like it was only the freshmen who were late to school. And something that is unique to the Scranton School District is that at the high school level, they do not have school district transportation. So students either walk, get a ride, or have to take public transportation to get to school. So this particular school not only has an adult PBIS team made up of a variety of staff members, but they also have a student PBIS team. And so they went to the students and they said, tell us a little bit about this. Why are so many students late to school in the morning? And it turned out that one of the factors, in addition to this, kind of obvious point that it's sort of this community data point around kids needing to get themselves to school, was that a lot of students like to stop in the morning for some sort of breakfast item. They stop for donuts, they stopped for sodas or coffee, they stopped at some sort of a store before coming to school. And so what they did, you can see in the picture here, is within their cafeteria, they essentially built this box that they turned into a little kind of coffee shop cafe where students could come into school and purchase healthy items, and also drinks, coffee, tea, hot chocolate. And this was one way that they could get students into the building and then hopefully to class on time in the morning. And so we looked at the data 1 year later, and it's kind of small there, but what you can see is in the first year of implementation of PBIS, they had over 700 tardies. And this year, at about the same time point, they had just around 300. So they cut in more than half the number of tardies they had just by kind of calling attention to the idea that this was a problem, rallying around the students' input as to something they thought would be effective in order to make a difference, and really did impact their data. And what they've done in the meantime is drill down further to see, of those 300 tardies, is it still in the morning? Is there a certain cohort of students we could target? Do we need to make some additional outreach to make sure that students are getting here and getting here on time?
This is Lucille. I just wanted to point out the reason I asked Kelly to share this example with us is even though tardies at the high school, kids being late to class, may sound like a non-mental health issue or a small issue, the youth voice was really critical here, and the community voice in terms of standing back and looking at this, quote, problem from a broader viewpoint, which again is embracing the system of care principles and the system of care values of more people, real people at the table, and listening to the voices of the people who live there and have them help solve the problem. And you're changing the school climate, and then you'll be able to move forward in terms of installing higher level interventions as we go over time. So Kelly's going to now share with us another example of how the community team, and we're going to switch from high school to little kids. So Kelly, tell us about the Pennsylvania example about the little kids.
Sure. And again, here, just to point out that those of you who might be hearing these examples from Scranton for the first time, please remember, we started this project in 2009. We started out small with just 2 of the elementary schools, and we've really focused on this idea of scaling and sustaining. We want to bring all 3 tiers of multi-tiered system of support to all of the buildings. We want to continue to bring in community partners, as our data sort of tells us that we need to address any gaps in our continuum of interventions. We want to be constantly looking at data, which we've started to look at more community data over time, and really just thinking about keeping at it. This is a process, and it does take time. So now, as Lucille said, in addition to the example I just shared, I want to share a little bit about an example related to kindergarten students within the district and how we're now making better outreach to our early childhood partners. We have district and community leadership team meetings quarterly, which is really following the implementation blueprint, but bringing in those community partners. And at a typical meeting where one of the agenda items had to do with some partners from the Commonwealth Medical College in Scranton, and the idea of they had gotten some grant money to put in some medical suites in the intermediate schools, the middle schools. And so during this conversation, of course, the other schools were saying, what about us, what about us? And we got to discussing this data point around kindergartners. So again, this was the 2013-14 school year. This was in the spring, so again, kind of around March. And the principals from the elementary buildings were saying, listen, we are really struggling with our kindergartners. We're spending lots of time in the buildings. We are seeing problem behavior all across the board. And so I'm just going to show you, again, this is from Swiss Office Discipline Referral Data, 3 different elementary schools where kindergartners had more office discipline referrals than any other grade in the building, okay? And so we said, all right, we've got to get some more people at the table, and there was some follow-up dialogue with Head Start, with our early childhood mental health partners, the IU, which is an intermediate unit who supports some of the districts in a couple of counties, community partner with the United Way, and 2 of our mental health providers. And what we talked about with these data points is we realized that over half of the children who were in kindergarten last year didn't have what we would call prior school experience. They didn't attend preschool, they didn't go to daycare, they weren't involved in any other services. And so we decided that we probably need several different strategies to address what we knew to be true about this data. And so we have in Pennsylvania, just like with school-wide, something called program-wide PBIS, where in our Head Start and early childhood classrooms, as well as private daycare facilities and other programs, they are implementing the principles of PBIS, but it's really geared to young children. And so we were going to partner with these folks to see how could we get more of the community agencies within Scranton to use program-wide and work with us to kind of get these strategies out there. Second, around the same time, Prevent, Teach, Reinforce for Young Children is a Tier 3 evidence-based intervention through, again, some of the national PBIS work, and one of the authors of this actually was in Pennsylvania, kind of by coincidence, but the Scranton School District nonetheless sent many of the kindergarten teachers and preschool classroom teachers to this training. The idea then was that they were going to come back and use the ideas from this manual, which is typically behavior support plans for individual students through this process of identification and function-based thinking and things like that. They were going to use some of the strategies for classroom management strategies. And then finally, we were going to look further at some of the children who were having ongoing difficulty in kindergarten and consider potential referrals for an evidence-based practice that the mental health providers were trained in, and that's called Parent-Child Interactive Therapy, or PCIT. And this is really a therapy where the family goes to the mental health clinic, there's a one-way mirror, and the therapist works with the parent on really general praise as well as how to correct their child, and literally focuses on that interaction between the parent and the child. The final thing that the district did by way of intervention was they put together a summer camp. This was funded with both Title I dollars and also support through the United Way, and they put together a 4-week program that included parent connection and some community connection, but really helped prepare these children who they knew were going to be coming in at the start of the 2014 school year, who had kind of that no prior school experience, and help get them sort of ready for the classroom, if you will. And so again, this all happened kind of at the tail end of the last school year. Over the summer, there were some changes in the district leadership. What I also know to be true, back to that first slide about the district, is they have many families who register for school right at the first day, which is after Labor Day for them. And so really, it's been a little bit inclusive so far, kind of a year later, but again, it is a process. We're going to keep at it. The leadership is very committed, and we're going to be kind of honing in and revisiting some of these strategies. Here in front of you now are 3 different websites that you can get more information about what's happening at the state level in Pennsylvania related to interconnected systems framework, as well as what's happening specifically in Scranton. And of course, we'd be happy to help you in any way that we can with whatever your questions might be.
Well, thank you, Kelly. Can you hear me, Kelly?
Yes, I can.
Okay, all right. So, and I see some chat going on in the room, and Kelly, you're getting some assistance from, I think, Lisa. And Allie Hearn from our Illinois team put up a link with Universal's screening tools and procedures that people have asked about. So we're doing our best. Colin, go ahead with the next poll, please. We're doing our best to get some resources up here in response to your questions, and thanks to the team who's assisting me with that. So we just wanted to take a pause for a moment and just think for a second. Have your experiences been similar to what has just been described as an interconnected system framework approach? We know this is rather new to have mental health providers embedded in the teams in the building, bringing data to the table and not coming to the table with preset interventions, but coming to the table to be part of the problem-solving process. So we see that some of you are having some similar experiences similar to the interconnected system framework, but a lot more of you, as I would expect, are not, and we're hoping this is the beginning of exploring and adopting such approaches in your community. Colin, can we go back to the PowerPoint, please? A couple more examples with you at Tier 1 and Tier 2, because, you know, most of our experiences with mental health have been at Tier 3, and we wanted to try to give you some Tier 1, such as our high school example and such as the preschool example had all three interventions at all three tiers. It had interventions for all the kindergartens, for some of the kindergarten kids, and for a few. And what I love about that Scranton example with the young kids is it really is a structure. They used the structure for developing the ISF of the district community team. They had a team that meets regularly. They look at district that crosses, our data that crosses across schools in the district, and they came up with a collective approach that we're excited that it's just in progress now. It's only been underway for a short period of time, just about a year, and so we're looking forward to hearing what they've been learning and what data that they're using. And just a quick commercial, our national PBIS leadership forum in late October in the Chicago area will have a strand on interconnected system framework, and Kelly will be doing a session updating us on the progress of things in Scranton, especially with regards to the preschool example. And back to the school level teams for a moment, I want to share an example with you of what happens when community providers can sit in on the Tier 1 team, which in Kelly's example, she already talked about bringing the youth voice in and the community voice to start to begin to solve some climate issues related to tardies. Here's what we mean when we talk about an expanded Tier 1. Looking at a broader range of data, looking perhaps at universal screening data that goes beyond what the school would look like on their own. And then all of the interventions involve teaching new skills. We all know the most evidence-based interventions for kids with mental health problems, whether it's depression, whether it's conduct disorder, whether it's OCD, whether it's anxiety, involves actually teaching our children and youth new ways of responding, new ways of coping. And so a lot of the interventions that you hear about involve that. This was an interesting strategy, an example that came out of actually a white paper we wrote on ISF in 2009 that was the precursor to the monograph. And we learned this example from Colette Lewick in Illinois from the Illinois Children's Mental Health Partnership, who was working and learning from community providers sitting on a school team near an Army base. And this was years ago, and you'll be able to tell what year this was in terms of the data here. One parent, living with one parent, students who were anxious about parents as soldiers were stationed away from home. And the mental health staff from the Army base worked closely with the school staff to bring in some strategies that all the teachers could use in terms of understanding how kids are feeling, understanding how to get kids grounded when they come in the door, connecting to their school-wide expectations of feeling safe, feeling comfortable, feeling respected. And that collaboration resulted in kids at risk getting calmed down, if you will, through some of the Tier 1 strategies. An example of a Tier 2 would be more what we're familiar with, where we're not trying to impact all the kids in the school by one strategy, which is what we do at Tier 1. But in Tier 2, we want to look at targeted groups of kids who need specific interventions, many of which can be delivered in groups. And the example I want to share with you today, and I'm really excited that I think Julie Cartel from Central Illinois is on here, and she taught us through working with some of our schools down in Central Illinois how to integrate trauma-informed interventions. And I'm quite confident that most people on the call are familiar with the research around trauma-informed interventions and understanding that trauma is actually a broad category, and part of installing trauma-informed interventions is helping all teachers understand the impact of trauma and the trauma domains that are affected, and the intervention, oops, that's a typo with that question mark up there, sorry about that, but the intervention that we learned down in Central Illinois was just one particular trauma-informed intervention. I'm not promoting one over the other. Some of you may be familiar with CBIT. But the one where we learned our interconnected system framework was when the mental health providers from the community, trained through a system of care grants and collaborating through the district team, brought to the attention of the school district the importance of addressing trauma and the fact that some of the data that they were seeing at the high school level in this example actually could be related to trauma, and help the schools move to a screening tool to find kids who had some behavior functioning that could be related to trauma, and then they put this Tier 2 group together using the Sparks curriculum that the system of care grant had helped the local community providers become trained in. And it involved a Tier 2 group that went beyond what school people had been doing in their social skills groups, in that, based on the nature of the kids and the data from the screening around trauma, in that it brought in some psychoeducational techniques. For example, school clinicians were learning from the community clinicians about using mindfulness and grounding exercises and having kids do what I call, I know this isn't the term perhaps they use, but giving an emotional barometer rating of where they are when the group starts, so that the facilitator of the group, the clinicians, can help the kids really focus and benefit from the group, talk about any issues that they brought in before they would begin their actual session-specific content and learning their skills. There's just a little information that we borrowed from a presentation done by one of the Sparks clinicians at a PBIS conference in Central Illinois. And what I liked best about it was when the clinicians stood up there on the stage with the kids who'd been in the intervention. Our system of care folks would have enjoyed it thoroughly, in that we did a little interview with the kids where they talked about the impact of the group and how they were transferring the skills to their life. But I loved how the clinician said up on the stage at the conference, this is an upper Tier 2 intervention. She said, we sit on the Tier 2 team. And she explained that the school staff identify the kids by using first their screening data and then employing a trauma-informed screening tool that the mental health center provided. And then the school staff make the initial contact, and then more screening and assessing, and then that the school-based clinicians and the community clinicians actually implement the intervention together. And so we're seeing more and more trauma-informed interventions as we move forward with the interconnected system framework in different states. And of course, at Tier 3, where we're more familiar with the integration, one of the exciting developments that we're seeing is mental health providers from community agencies and school clinicians, social workers, psychologists, etc., being trained together to facilitate person-centered wraparound plans, including the wraparound application of Renew for our older high school kids. And we're seeing co-trainings where school staff and community staff go through training together and work together to decide who should facilitate which kid and which family based on their needs. So for example, the kids in the families that have a higher level of community needs and a broader range of medical and mental health needs, it might be good for the community facilitator to take the lead in that particular wraparound, whereas with another kid and family, they might co-facilitate a school facilitator and a community facilitator, or the school facilitator may take the lead in certain circumstances. So we're getting very excited about seeing the interaction and collaboration. Instead of being a referral to the mental health center, it's a collaborative decision about who's going to facilitate the intervention, and a confidence that no matter if the facilitator comes out of the school end or the community agency, that we will have a similar experience and a similar process as the family and the youth are guided through the person-centered wraparound and renew process. So those are our examples at all three tiers. At this point in time, I would like to turn the rest of the session over to my colleague Susan Barrett, also from our PBIS team. She's located in the Mid-Atlantic PBIS network. I probably failed to mention I'm located in the Midwest PBIS network, both partners with the National PBIS Center. And Susan and I are pretty excited about next steps with the Interconnected System Framework, and Susan's going to introduce you just briefly to some of the tools that are available and tell you about an invitation and an opportunity we would like to offer to you to participate perhaps in a smaller learning community than on these basic calls that we have scheduled, for people who really want to participate in a pilot of implementing some of the tools that Susan's going to share with you. So at this point, I'd like to introduce Susan Barrett. Susan? Susan, are you there? Can you speak? Are you on mute? Not hearing Susan. Colin, can you check on Susan's connection here and make sure she's not muted? Mute is off. Not sure why you can't hear me. Let's let Colin intercede for a moment and see, Colin, if you can get Susan. She's not muted, but she can't be heard. Okay, while Colin works on that, Susan, I'm going to go ahead and start and just cut in when hopefully Colin will figure out how to, he's having you call back in on the line. All right, so I'll get us started. We're pretty interchangeable here. We just thought you might want to hear somebody else's voice. Hopefully Susan will be able to talk to us in a minute. She's calling in again. But the appendices of the monograph with the focus on tools, there is a district community level planning guide, which is a very, very simple tool to guide a district team through the organization and setup of their district community team. And then most of our tools at this point are tools that are available for use at the school level. For example, there's a survey on readiness for interconnecting positive behavior interventions and support that hasn't really been piloted very much yet, so we're interested in whether people would like to use that. But we're also working on a fidelity tool to measure the fidelity of the interconnected system framework in terms of its application in the schools. And currently my favorite tool is the Consumer Guide to Selecting Evidence-Based Mental Health Services. And I guess it's my favorite at this point because even if your system isn't well set up yet, we're finding school teams and community teams can at least begin to use the consumer guide to make sure that the practices that they're choosing are evidence-based. You can find these tools in the appendices of the monograph. We can see there's others that I haven't mentioned. So these are available for your use there. And the District Community Leadership Team Implementation Planning Guide actually walks teams through, and this is a newer tool, walks teams through exploration, installation. Anybody recognize these phases of implementation? This comes from implementation science. And so the tools also follow the implementation science. So this tool that is in development, let me go back again, it's the District Community Leadership Team Implementation Planning Guide. This is one of the tools that is under construction right now, and one of the ones that we're interested in having you use, right? And this will be used by the District Community Leadership Team in order to guide the cabinet people. Remember, we talked about people who have the ability to allocate resources, but to guide them through the development of the framework, policy, resource allocation, implementing an integrated multi-tiered system of support, and developing an implementation plan. And that's the key right there, is the team needs to work on the development of the plan so that it can decide which buildings to provide with which support over time. And part of that plan is an evaluation plan to assess the fidelity and the outcomes of the interconnected system framework, which will involve the use of some of the other tools, right? The other part is what training and support do our staff need, and also acknowledging that we need to spend time getting the system up and running, and we got to work on the system features if it's going to sustain over time. And the exploration stage, I'm going to go through some of these rather quickly. We're not going to get into the details of all the tools at this point. This is intended to be a quick overview. And the exploration phase, if you're familiar with the phases of implementation, obviously this is the design, the decision to explore, then moving into adopt the tool. This is a screenshot of what the school is going to, what the tool is going to look at. And the key here is these guiding questions. So this is when the team meets, you can actually use this tool to walk yourself through, as you can see, more of the guiding question: what's currently in place, is there consensus about identified goals, how will they be communicated? Then we move into, this is the parent-family engagement section of the exploration phase with specific questions towards that, specific questions around database decision-making. This is about local knowledge and development, and then we move into the installation phase. And as the group moves into the installation phase, notice that the questions over here are specific to that particular feature, right? Same thing, so I'm just going to go through the screenshots here. Installation, guiding questions. So this is, again, my favorite part, intervention selection, right? Okay, and this would be what current practices and initiatives that are enablers or barriers, walking through, getting down to intensity of the challenges, did we screen? So as you can see, this is getting into the nitty-gritty details of installation, going through that, and following that will be full implementation. So that's the tool that we're currently working on, and we're looking for participants to, anybody here who wants to work on a small pilot of being walked through and provided with technical assistance by Susan and others and myself on the use of that tool. Another tool that we mentioned that we're pretty excited about is a survey on school readiness for interconnecting positive behavior supports and school mental health. It's currently available and in the monograph. Came out of a doctoral study with Victoria, supported by Dr. Mark Weiss at the University of South Carolina. And the purpose of this one is to evaluate readiness, and just showing you some screenshots here. The tool is set up on a Likert scale, and it's a self-assessment, and the group using the tool can decide which of these areas to work on. Now you'll notice it jumps right into school staff apply PBIS principles to content areas other than their own. In other words, are the school staff looking to use the framework beyond just office discipline referrals and teaching of behavior expectations? And it moves from there. We heard from Susan Bruce at the State Department in Iowa a couple weeks ago, and she told us that she used this team tool along with another tool called District Capacity Assessment, which is a intervention neutral tool. And she used the questions from this PBIS school mental health tool to guide a district leadership team through the design of their school mental health integration. And so this survey is just some screenshots. Again, families view, I noticed right there. And here we have moving into teaming structures, moving into professional development, youth participation, and so that's that tool. The third tool that we're...
Can you hear me now?
Susan Barrett, welcome. You can take over on the Consumer Guide tool.
Yay, it worked. Sorry about that, guys. Took me a couple times to call back in. So thanks, Lucille, for covering. Want to introduce you to a couple more tools, and then we're going to move into ways that you all can help us build some of the fluency with some of the new tools that are being developed. This is another school level tool that we are using that allows folks to select evidence-based mental health services. So schools that are already implementing a school-wide PBIS model are wanting to expand the number of interventions made available to their students. And so one of the things that we know is that after a recent meta-analysis is that students who received evidence-based interventions were functioning better after treatment than more than 75% of children in the control group. And so the purpose of this tool is really to have this guide, have the integrated systems teams inside the schools who are interested in expanding those continuum of supports and mental health services, invest in a formal selection process that will enable them to better identify evidence-based practices that were specific to the needs within their school. So we have a list of where to find some of those mental health evidence-based. There's a couple of websites that we've listed on this tool that you can go to review what's out there. And again, not because, just because it has evidence-based doesn't necessarily mean that you need it. We really want to do a careful needs assessment to make sure it's the proper match. Oftentimes we think more is better, and so again, one of the ways of work in this ISF kind of logic is that we're investing in a small number of evidence-based practices that yield high impact for the group of kids and youth who we're serving. So it's really important that when you invest in something that you're investing in something that does have evidence-based, and we worry a lot that many websites now contain kind of a mark on the website that says that it is evidence-based when in fact that is not the case. So we have carefully identified some websites that might help you navigate through that. Typically, again, I think our hearts are really big and we want to do as much as we can for the students that we're serving, but on average, a typical school delivers 14 separate programs. And we know that when you have few resources within the school, having to do 14 different types of programs may not yield the best outcomes for kids. So we really want to kind of narrow the number of programs and services that we're providing our kids and make sure that we have high quality implementation rather than thinking that more is necessarily better. So this tool allows the school team to go through a selection process, making sure that we are considering the developmental level of the students that we are serving, making sure that we've got expertise within the building and community that allows us that high quality implementation, and making sure that it's culturally appropriate. Again, that match is really, really critically important. When it comes to actually implementing, we want to make sure we have high quality, high fidelity. So we are asking that we put a fidelity measure that's linked with the evidence-based practice that we're that we're focusing on and that we're getting the outcomes that we want to get. And so here are some examples of the way that we're collecting data with regards to outcomes. The other aspect of this tool that we really want to focus on is the system features that are critical to implementing with high quality, high fidelity. So we want to make sure that we've got that formal process really rigorously being conducted by the leadership team, that we're building internal capacity so we're not relying on external providers to be able to deliver training and support, that we have sufficient funding over a long period of time, and that our administrators are really having that kind of overt political support alignment and making sure that we're highly visible with our community and bragging about that we've got access to an evidence-based practice that is making an impact with the students that we're serving. So there's that portion. So then the last tool that we want to share with you is one that really focuses on the extent to which ISF is in place with fidelity. And so if you're a school system that's familiar with PBIS, this is an expanded version of the benchmarks of quality. And we're not so sure about the name at this point in time, but we're kind of testing out the name benchmarks of interconnected systems. And the purpose of this tool, again, is a school-level tool that's guided, that's completed by the systems-level team at the school. And the purpose of the tool is to assess what is in place across all three tiers, to use it as a planning instrument to guide development of the implementation plan at the school level, and then finally to monitor the progress of implementation. It can be quite daunting, the level, the kind of workload that we're talking about. And this graphic kind of demonstrates all the work that's involved when we're thinking about connecting school mental health and PBIS. You can't read any of this, so we'll make sure that we send you a copy that is readable. But in essence, it allows the team to go through by tier and sort of self-assess the extent to which critical features are in place around progress monitoring, around do we have the right people at the table, around making sure that we're building skill sets with our staff. And so, again, it's a self-assessment tool that allows for those critical implementation actions that need to transpire in order really to be effective. So that was kind of a review about some of the tools. I'm sure that a lot of you, when you were listening to Kelly and Lucille talk about some of the specific ways that ISF has been installed in the schools that they're working with, you got really excited. And one of the things we know is that this work is really complex. We've had a lot of systems and structures that have been in place for a long time, and breaking down those barriers to be able to move into using evidence-based practices, having a system that supports that can be quite overwhelming. So we want to make sure that you're using and have access to tools that help structure some of those important conversations that you're going to need to have as you move through the process of implementation. I also want to make sure we're really clear one more time that, when Kelly was describing that they've been doing this work since 2009. So for 6 years, she's been working with a group of schools in Pennsylvania to cultivate the interconnected systems framework. So this work does take time, and again, it can be very complicated and complex work. So we want to offer multiple opportunities for those of you who are interested in learning more about this and perhaps getting more support and guidance. We want to offer a learning community for you. And we've got several ways in which we want to be able to do that. So the first question is, are you interested in learning more? Do you want to join this work? What are some of the ways that we can help you? What are some of the ways that we can kind of slow down, break those walk through those tools a little bit slower and give you additional support? We have a couple of options on the table here. The first one is our invitation to join some of our monthly calls. I'm throwing up some dates in the chat box. to make sure that you have dates on the calendar for these monthly calls and kind of what we're going to go over during these calls. As you know, this call is really an intro to ISF. We have follow-up calls. The second call is April 29th. And then we're going to be talking on June 2nd. And then again on August 11th. So let me see if I can.
I got those I'll put them in the chat room.
Okay, great.
Those are our already scheduled webinars on the broader implementation topic. And now Susan's going to talk to us about an additional set of calls for those who want specifically to participate in working with us to advance the use of some of the tools. Susan?
Right. So the additional dates that we have are June 30th, July 30th, and August 28th. So ignore the June 2nd date down at the bottom. But we're really interested in identifying a couple of sites to have a smaller group come together more frequently in a much more targeted approach. You know, one of the beauties of ISF is that we identified knowledge development sites and blended school mental health and PBIS together. And now we really want to have some knowledge development sites that also crosswalk system of care and really blend system of care in education. So we're inviting 3 or 4 sites to participate in option 2, a targeted approach that can spend 3 more times with us or more if you're interested to kind of teach us and use some of these tools and align it with some of the system of care work that's going on in your communities. We also would like that smaller group to contribute to a technical brief that describe ways that your sites are working to blend system of care, PBIS, and school mental health. And so a couple options there on the table for you. Again, option 1, to continue to come to these calls and sit and listen to all of the work that's going on with ISF, and then option 2, a more targeted approach if you want to kind of get more in-depth details and have access to a little bit more of a targeted approach with training and technical assistance.
Susan, what's your June date on option 2?
Sorry, the option 2 is actually June 30th, and I put it up in the chat box. I corrected the dates up in the chat box for you.
All right, and I'm doing that as well.
Right. I also wanted to make sure that you guys knew that the under option 1, some of the so the next time we talk, we're going to be focused on installing ISF and some of the local experiences some of our sites have had with integrating system of care and education. On June 2nd, we're going to be talking about the role of the school and community-based clinician. And on August 11th, we're going to be talking about innovations with ISF, integrating restorative practices in schools. So those are some of the topics, and again, I put that level of detail up in the chat box, and we will certainly include that when we send out our final PowerPoint presentation.
Julie Cartel from Illinois has a really good question, as usual. Thank you, Julie. She wanted to know for option 2 for the small group work with the small sites, should the lead partner be a school or a community? Julie, we don't care, but we'd like to have one of each. We don't care who you call the lead, but the ideal for the use of the tools with the more specific technical assistance option 2, we'd like to have a partnership of at one school and one community provider. If you cannot come up with both people to participate, but you have people to participate with after you participate in the option 2 calls, that's fine too, Julie. What we're looking for is a couple of sites that actively have enough of relationship and setup to actually go use some of the tools. So now, Susan, can you answer the question how they let us know if they want to participate in option 2? We already, by the way, have some sites we've been speaking with that may be on this call already, but we wanted to open it up in case there were some more. Susan, should we just type our email address into the chat, or we were going to have or do we want to send everybody out a form that they can fill out?
Why don't you email me and if you're interested to learn more, and then we can kind of take it from there. I think a lot of this depends on the interest level. So if you are interested in learning more about joining the group, just email me and we'll move forward from there.
Great. What we've talked about is sending everybody who's interested just a couple of question survey so that we can make sure, A, we don't get too many, and B, we get the right people. So if you're interested in participating and you believe that you have or can create enough of a structure to try out some of the tools in partnership, even if only one of you can come to the option 2 calls, please email Susan and we'll look forward to another conversation. I can see we're just about out of time. In spite of the tech difficulties, I think we pulled off getting all the information, and I really want to thank a lot of our supporters who are working with us to answer a lot of the questions that are on here. And we will stay on here for a couple of minutes and check to see if there are any more questions people are asking that we can answer. So I think, Colin, you can leave this open for another 5 or 10 minutes, even though we want to honor the time now being 3:30 Eastern Time. And thank you so much, and we look forward to talking with you in our April webinar, where New Hampshire will be presenting their use of tools at some of their school sites. And after our April, then in June, and in August, these general calls with lots of people. And we look forward to hearing from some of you who want to participate in the smaller calls where we won't be so muted, and we will keep it small and more interactive around use of the tools. And yes, this is open, Lizette, to, that's a beautiful name, I hope I said it correctly, all states. Anybody who is interested in using the multi-tiered PBIS framework as a way to integrate mental health and expand the options at school level, and would like to apply the interconnected system framework using some of the tools, and perhaps participate or have your site be written about in a technical assistance brief over the next year, which is not mandatory for participation, but yes, open to everybody. So on behalf of Kelly and Susan and myself, we would like to thank you all for being here today. We want to thank Colin and the Institute for their support on the technology, and Marlene and Denise and Michelle Zabel for their leadership and making integration with education a current priority for our system of care sites around the country. So thank you and have a great afternoon.